Dr. Grant Ralston here for Strength Physiology Online, delivering a micro lecture of a Level 4 mental health course, and we are focusing on Unit 3, Schizophrenia and Physical Health and Exercise, looking at physical activity as a means or as an intervention for this specific population group. So the objectives of the micro lecture is getting us to understand what schizophrenia is and physical health. Also looking at self-reporting physical activity measures in schizophrenic populations and factors that influence physical activity in schizophrenic populations. In addition to this, we're looking at physical activity interventions with this population group and the role of promoting exercise in treatment of this disorder. So, schizophrenia is a serious mental illness that is characterised by psychotic symptoms, and these can include hallucinations and delusions, as well as organised or disorganised speech and behaviour, negative symptoms, and serious neurocognitive and social cognitive defects. So the range and nature of symptoms in schizophrenia vary widely among individuals, but can be divided into positive and negative symptoms. The positive symptoms reflect an excess or distortion of normal functions, including delusions, hallucinations, and thought disorders. The negative symptoms can reflect a reduction or loss of normal functions, including active flattening, apathy, avalation, social withdrawal, and cognitive impairments. The use of antipsychotic medication is the standard treatment for schizophrenia. Although such medications can be effective for controlling the positive symptoms of the disease, it is typically less effective in elevating negative symptoms and cognitive deficits. The Nature Journal has described schizophrenia as the worst disease affecting mankind, and that was an editorial in 1988. And given the extent of disability associated with the disease, schizophrenia is usually experienced by people first at a young age and then throughout their life. Individuals who live with schizophrenia experience distortion of reality, changes in thinking and perceptions, difficulties in social situations, and problems with daily functioning. Based on current estimates for epidemiological studies, approximately 15.2 individuals of 100,000 develop schizophrenia annually, and the lifetime prevalence is 4 in 1,000 individuals. And that came from the study of McGrath and colleagues in 2008. So what about the life expectancy? The life expectancy of individuals with schizophrenia is approximately 20 to 25 years less than that of the general population. There's recent data that suggests that this mortality gap is widening, and a series of reviews have concluded that patients with schizophrenia die from suicide at increased rates compared with the general population. However, it's important to note that excess mortality from disease accounts for even more years of life lost in these patients than does suicide. This increased rate of mortality is reflected in higher rates of morbidity, and reviews confirm that between 35 to 70% of individuals with schizophrenia have an additional morbidity. Almost all disorders occur at rates that are higher than expected, but the prevalence of cardiovascular disease and diabetes is particularly elevated in this population group. Potential causes of this excess mortality or morbidity are varied, but can be broadly categorised in terms of changes in treatment. And that includes the metabolic side effects of a typical antipsychotic medication, as well as greater prevalence of engagement in unhealthy behaviours, including a lack of physical activity, poor nutritional habits, as well as smoking and drinking. And also with this is a limited access to healthcare provisions. Because health behaviours are potentially modifiable and because empirical-based interventions that address the increased risk of obesity, CVD and metabolic disease in the patients are lacking, attention has turned to the health behaviours of individuals with schizophrenia. Research is urgently required in developing evidence-based behavioural interventions for preventing and treating premature morbidity that are specific to this population. And one element of such efforts is reducing the high prevalence of physical inactivity, and that is a priority given the well-documented physical health benefits of physical activity. So what about physical inactivity with this population group? Physical inactivity is in itself a major cause of morbidity and mortality, and also merits the same level of concern as other risk factors for cardiovascular disease. Individuals with schizophrenia are less active than individuals in the general population, and the majority of individuals with schizophrenia have lower cardiorespiratory fitness and physical functional capacity compared with population standards. When we look at clinical samples, it demonstrates that the prevalence of smoking is high, between 58 to 88% in patients with schizophrenia, and that the prevalence of physical inactivity can be even greater than that of smoking. For example, in the most comprehensive study of physical activity using accelerometers in a clinical population group, 96% of the sample did not perform at least 150 minutes per week of moderate to vigorous intensity physical activity in bouts of at least 10 minutes. And that was the work by Jerome and colleagues in 2009. In a validation study, 74% did not meet physical activity guidelines of at least 150 minutes per week of moderate to vigorous intensity physical activity. And that was Faulkner, Cohen and Remington in 2006. Therefore, physical inactivity should be considered a risk factor that is comparable with smoking, particularly in terms of prevalence for individuals with schizophrenia. So there is some evidence that shows that regular exercise is an effective strategy for preventing premature mortality, cardiovascular disease, strokes, hypertension, colon cancer, breast cancer, and type 2 diabetes in the general population. Nothing suggests that such evidence would not only apply to individuals with schizophrenia. So when we look at this self-reporting physical activity in this population group, what we're really going to just pull apart is one or two studies. So Faulkner, as I discussed earlier, Cohen and Remington, that study, examined the reliability and validity of the International Physical Activity Questionnaire, a self-reported physical activity questionnaire that is commonly used in adults and is available in multiple languages. The Faulkner study found adequate 1 week test-retest reliability with a Spearman Rhino of 0.68 and concurrent validity of 0.37 between total minutes of physical activity as assessed on the IPAQ and accelerometer among 35 outpatients with a Diagnostics and Statistical Manual of Mental Disorders 4, Diagnosis of Schizophrenia. The validity and reliability improved for individuals who had first been treated for schizophrenia within the past 5 years, and this may reflect declines in cognitive functioning that are part of the aging process and that are exacerbated by medical illness, medicational side effects, and environmental understimulation. On contrast to this is the work of Lindemeyer and colleagues in 2008, and they examined the test-retest reliability and concurrent validity of the Yale Physical Activity Scale. And that was among 55 outpatients with schizophrenia. They reported that the YPAS was a reliable measure of physical activity in individuals with this disorder or disease for some indices. Although the YPAS demonstrated concurrent validity with other self-reported measures, it did not demonstrate concurrent validity when compared with physical activity as measured by the accelerometer. Both validation studies caution that self-report measures might be useful only as a surveillance tool for assessing levels of physical activity in populations, but these measures need to be complemented by objective measures of physical activity, particularly when assessing the impact of interventions at group level. Moving on from there, we're going to look at the Faulkner, Cohn and Remington studies we said, and the Marzolini and colleagues study. So given the inherent physical health benefits of regular physical activity, interventions for promoting physical activity should be integrated into mental health services. An additional benefit of participation may be improvements in the mental health, and importantly, in its own right, but possibly critically for continued participation in the physical activity that is necessary for physical health benefits to accrue. The work by Faulkner, 2005, just at the left-hand side of the PowerPoint, reviewed the evidence of the effects of physical activity on the mental health of individuals with schizophrenia. Although they noted the methodological flaws in the literature, they concluded that some preliminary support shows that participating and engaging in exercise is associated with the elevation of negative symptoms associated with schizophrenia, including depression, low self-esteem, and social withdrawal. These conclusions are drawn, however, primarily from studies of pre-experimental design. The other abstract put at the right-hand side of this PowerPoint is a study by Marzolini and colleagues in 2009. And what they did look at was they randomised participants to either a combined aerobic and strength training group or a standard care group. Participants in the combined exercise group met 2 times per week for 12 weeks. And the sessions were led by a cardiac rehab exercise specialists. They were 90 minutes in length and consisted of a brief warm-up, resistance training, aerobic training, and short cool-down. The mental health inventory showed improvements in participating rates for depression and a positive effect, as well as behavioural and anxiety. But changes weren't statistically significantly different from the control groups. So similarly, fitness improvements were found for the exercise group, but no significant differences were suggested or found between the treatment and control groups. So what about physical activity interventions continuing? So I included another two studies. And the first study to the left, conducted in 2007, reported that participants took part in a 3-month program of either yoga or aerobic and stretching exercises 5 days a week for 1 hour. 5 days a week for 1 hour. The scores on the positive and negative symptoms scale and the social occupational functional scale decreased significantly in both groups, and greater decreases were found in the yoga group. In a study by Behere and colleagues in 2011, the right-hand side of the PowerPoint, 66 outpatients were randomised into an experimental yoga group, an aerobic and stretching exercise group, or a waiting list group. Participants in the yoga and exercise groups received 1 month of instruction and then were asked to practice yoga or aerobic and stretching exercises at home. Participants' caregivers were asked to monitor yoga therapy and keep a log. After 2 months of home-based yoga or aerobic and stretching exercises, ratings on the positive and negative symptom scale and social occupational functional scale decreased from baseline in both groups, but changes were significant only in the yoga group. Where these findings are generalisable to the Western setting and population isn't really known yet though. However, the studies that we've talked about so far show that exercise therapy can have a modest positive impact and no adverse effects on some components of mental health and a limited effect on physical health outcomes, including weight. When we look at the study designs, there is issues and questions with heterogeneity in study designs, the intervention types and outcome measures, and that really does make it difficult to draw clear conclusions. The included studies that we've just put together, it is possible to conduct randomised controlled trials or RCT trials that examine the mental health effects of physical activity with individuals with schizophrenia. However, the studies are generally short-term and only include small sample groups. And importantly, the attribution rates were similar among the trials, and no significant differences between groups were found. So what about the promotion of exercise and the treatment of schizophrenia? The sort of results indicate that individuals with schizophrenia can improve components of mental health by engaging in exercise. However, the guidance regarding the specific dose of exercise that works best for augmenting and improving mental health is very much limited by the number of small studies and the variability of the intervention types themselves, as well as the intensity and duration. It's important to note that people with schizophrenia should be encouraged to ask the clinicians or the doctors for support and advice regarding becoming more physically active. Similarly, doctors should educate the patients, family and caregivers about the metabolic risks associated with antipsychotic medications and provide lifestyle advice regarding diet and physical activity. Again, that was a follow-up work by Faulkner and colleagues in 2007. The common physical activity guidelines, and what I've included here at the right-hand side, is the accumulation of 150 minutes per week of moderate to vigorous intensity. And that appears to be applicable and relevant to individuals with schizophrenia in terms of potential benefits for mental and physical wellness. However, theoretically driven research and practice are required to examine how to reliably help individuals with schizophrenia adopt and maintain physical activity in the face of significant motivational and cognitive deficits that are inherent to these population groups. Such work will also be needed before specific types of exercise intervention are more broadly disseminated to this population group. So we're going to start looking at the self-efficiency model by Bandura. So there is some suggestions for practice that can learn from the literature and clinical experience. The work by Richardson and colleagues 2005 demonstrates and describes examples of structured, supervised, facility-based exercise programs, as well as lifestyle physical activity interventions that encourage participants to incorporate walking into everyday life and discuss a range of practical issues related to promoting physical activity. More broadly, grounding physical activity interventions in the tenets of social cognitive theory, this is the work of Bandura in 1997, seems to be a reasonable basis for developing interventions in the absence of compelling theory-based interventions. In the self-efficiency or efficacy theory, participation in physical activity could be viewed as being influenced by both cognition, that's the values, beliefs and attitudes, and external stimuli, that could be conforming to social norms and access to the facility. So self-efficacy is a situation-specific form of self-confidence, and it's integral to social cognitive theory and is a robust predictor of behaviour change in a variety of situations. Additionally, self-efficacy has been found to be a significant predictor of physical activity among individuals with schizophrenia and in a broader samples of individuals with serious mental illness. Bandura in 1997 describes 4 sources of self-efficacy, including, as you can see here, past performance, vicarious experiences, social persuasion and physiological factors. Each can be considered in the context of physical activity promotion in this specific population group, and we'll just talk about some of it. When we look at past performance, sometimes reviewed as past experiences. So past performance is considered the most important source of an individual's self-efficacy. Given that many individuals with schizophrenia have low initial fitness levels, and that drowsiness and fatigue may be side effects of some of the medications, a very gradual approach to increasing physical activity is necessary. Determining an individual's activity history and interests maximises the potential for success by ensuring that a match exists between those interests and the type of activity being promoted. And that could include group versus individual or structured exercise versus this lifestyle physical activity. Participants need assistance from the exercise practitioners in setting appropriate realistic goals for increasing physical activity, as well as developing the skills of self-monitor achievement. Attending group sessions or using pedometers to track physical activity can also be advantageous. When we look at the vicarious experience or modelling, it sometimes looks at seeing others succeed. So particularly with those who are similar to oneself, can be another source of self-efficacy. Individuals with serious mental health illness, such as schizophrenia, are more likely to be socially excluded, poor, and also unemployed, living in a substandard housing and have reduced social networks. And that was found by the Sainsbury's Centre for Mental Health study in 2002. Previous research suggests that social networks of people with schizophrenia are significantly poorer than those of a control group in both the quantity and quality, and that most want more social contact. The strength of social support may be a key determinant of the quality of life in people with schizophrenia, and it has been recommended that interventions in mental health care target increased social interactions as an outcome. When we look at social persuasion, social persuasion concerns verbal and non-verbal tactics used by others to promote a person's self-efficacy. The opportunity for consistent and structured physical activity experiences needs to be integrated into the delivery of mental health provisions and services. And this requires interdisciplinary and collaborative coordination of appropriate personnel, resources and faculties. So intensive support will also be required over a long period of time to help people with schizophrenia initiate and maintain physical activity. So lastly, we look at the physiological factors and emotional stress and states. An individual's physiological and affective states can also be a source of or threat to self-efficacy. In these circumstances, the threat could be taken into account in understanding behaviour and also the affective response to that bout of given exercise. By providing a supportive, non-threatening and intimidating environment with no pressure sessions allows people to go at their own pace, and that can actually help reduce anxiety about engaging in that physical activity session. And it's important to note that maybe a person's perception of physiological responses to exercise might alter the person's self-efficacy. And that is the extent to which a bout of exercise makes someone feel bad rather than good may be associated with non-adherence, and then that can ultimately lead to dropout. Encouraging individuals to monitor how they feel before, during and after bouts of physical activity might help them develop the skills to reliably do this, as well as encourage awareness of how physical activity might positively regulate other moods, emotions or feelings. And these can include fatigue, poor concentration or sleepiness. Research to assess this possibility is required, and unfortunately presently there's a lot of opportunity for moving the field forwards, so there's a lot more work that needs to get done. So to summarise, given the inherent physical health benefits of regular physical activity, interventions that promote physical activity should be integrated into the delivery of mental health provisions and services. In addition to physical health benefits, preliminary evidence shows that by engaging in exercise, it has an association with the elevation of negative symptoms associated with schizophrenia, including depression, low self-esteem, and social withdrawal. It's important that practitioners should seek to educate the client or the patient, as well as the family and caregivers, about the benefits of physical activity. And the physical activity guidelines of 150 minutes per week of moderate to vigorous intensity appears to be applicable and relevant to individuals with schizophrenia in terms of potential mental and physical health benefits. Physical activity should be increased very gradually, however. It's important that we should help patients be physically active in ways that promote self-efficacy, and also to help patients build mastery through goal setting and develop specific, detailed plans for behavioural change. And by developing opportunities for social support and giving ongoing feedback and reinforcement, these patients' efforts or clients' efforts may increase their physical activity levels, and by structure opportunities so that they actually enjoy the process of being physically active. So there we have it, just a small micro lecture today for Unit 3 looking at schizophrenia and the benefits of exercise.